Welcome, HAE friends, to this installment of our HAEA Webinar Brief series. This is Tony Castaldo, CEO of the HAE Association. Now, over the years, many people with HAE have been reluctant to seek dental care because trauma to the tissues in the mouth can cause an attack that could potentially progress into swelling of the airway. Now, there was an important study published last month in a prestigious medical journal that looked at the dental hygiene practices of the HAE community and compared them to those of the general population. And we are very fortunate and delighted to have the author of this highly relevant research, Dr. Jonathan Bernstein, who is globally known as a key opinion leader in HAE research and clinical care. Dr. Bernstein's name always comes up in any discussion about the remarkable strides that have been made in bringing safe and effective HAE medicines to our community. He has always been a leader in advocating for and participating in HAE clinical trials. Dr. Bernstein is a member of the HAEA Medical Advisory Board and sees a large population of people with HAE at the Bernstein Allergy Group and the Bernstein Clinical Research Center, both in Cincinnati, Ohio metropolitan area. He is universally loved by the people with HAE that he treats, and that makes a lot of sense because every year he appears on the list of best doctors in Cincinnati. Welcome, Dr. Bernstein, and thanks for taking the time out of your busy schedule to participate in this webinar brief.
Thank you, Tony, for asking me to participate. And I appreciate all the kind words, but certainly this is a labor of love. We really do care about the well-being of our HAE population, and the strides that have been made really are attributed to the patients themselves, your organization, which has been an incredible advocates for this disease. And without the HAE organization, I don't think we would have made it to where we are today.
Well, the Bernstein family has always been very much involved in this right from the beginning, and the your late and great dad, Leonard, certainly was a founder, and I know your brother also participates. So, it's just really been a family affair for many years, really. I know you've been practicing since 1990. So congratulations on the excellent study that you just published. And could you put your researcher hat on for a second, Dr. Bernstein, and discuss how the study was conducted and explain the major findings regarding dental care and the HAE community?
Well, it's an interesting study because this is the first study, to my knowledge, that really is a joint effort of the medical advisory board members of the Hereditary Angioedema organization, where we worked together to develop a comprehensive questionnaire survey. But it was an ambitious study because we collected over about 250 HAE patients and over 250 matched controls. So this was the essence of the study. It was then, of course, analyzed to look at differences between groups, but also intra-group differences, so within group differences. So that's what the data that we put forth in the manuscript represents.
And could you briefly go over the fundamental findings of the study, Dr. Bernstein?
Well, there's many facets to it. It's actually a fairly complex study from an analysis perspective. But certainly there are definite differences between the HAE population and the general population in terms of their utilization of dental care resources. But we certainly see that within the population that has had experiences with severe attacks related to dental hygiene or dental procedures, there is definitely a reduced frequency of dental care visits and some indication that these patients are using alternative dental hygiene methods potentially to delay the need to see the dentist, such as electronic toothbrushes or antibacterial toothpaste and so forth. So we see that there's no difference with respect to insurance coverage going to the dentist between the normal general population and HAE populations. So it doesn't seem to be a variable that affects these frequency of dental care visits, whether they go every 6 months or greater than or less than every 6 months to the dentist. It's really more related to their experiences, their negative experiences with swelling episodes. Clinicians, I don't think routinely question their patients about dental care. I think whether they have HAE patients or not, I don't think that generalists in normal individuals without HAE even talk about dental care. In medical school, it's given very little attention. I think we had 1 or 2 lectures on the mouth and the dentist. But dental hygiene is extremely important in general, and it's even highlighted even more in HAE population because of this potential outcome. So we need to incorporate this history in our regular routine histories for patients, and especially for HAE patients.
Well, certainly the landscape now is changing, again, based on the wonderful work that you and our medical advisors and others, both here in the United States and internationally, have done in terms of getting us better treatments. But I guess my question to you is, how do you approach a patient when you're speaking to them if you sense that they're a little reluctant to go to the dentist?
Yeah, and it's an interesting discussion because it's changed over the years, as you've known. Back in the day where all we had really were androgens and fresh frozen plasma, and now we have these spectrum of therapies, choices to use that are very effective for treating acute as well as prophylactically to prevent attacks, and the whole question of short-term prophylaxis. So what do we advise our patients? Well, I always try to ask, first of all, what is their experience, with not just dental procedures, but any kind of physical trauma or medical procedures. Are they someone who is susceptible to this as a trigger? As you know, not everybody has the same triggers. They're very different. And some patients undergo invasive procedures and have no trouble. Others don't. Others have major issues. So we have to get that history. We have to obviously do everything we do normally. We talk to them about the frequency of attack, the severity of the attack, the location of their attack, the types of treatments they have currently, the types of treatments they feel comfortable using. And then, and again, today it's much easier because, at least in our very severe cases who are on prophylactic therapy, which today are predominantly HAEGARDA, which is C1 esterase plasma-derived C1 esterase inhibitor administered subcutaneously, versus Takhzyro, which is a monoclonal kallikrein inhibitor. These are both been shown to really be extraordinarily effective at preventing HAE attacks. And that conversation changes. Do we need to have them use short-term prophylaxis just rote, just automatically? Or do we actually say, okay, well, you're not somebody who's had attacks, you're not at high risk, you're not having attacks, and we use shared decision making with the patients. What do you want to do? What do you feel comfortable doing? Well, doc, I feel comfortable just taking an on-demand therapy there and having it available, recognizing that swelling is not rapid. It does take time to evolve, and that the treatment can be administered. And in our experience, most of these patients who are completely controlled, who have not had attacks, and over a year or two in many cases on these prophylactic therapies, have done beautifully, done well. Now others are a little bit more reticent and a little more concerned, and we involve them in the conversation. If they want to use an on-demand therapy, that's not a problem. The difficulty is that most patients today are restricted by insurance of having only one on-demand therapy. And so they don't all have the options of using what is considered, the best options, like a C1 esterase replacement therapy, whether it's a plasma derived or a recombinant form of that therapy. And they may only have a bradykinin 2 receptor antagonist. Is that sufficient as a short-term prophylactic therapy? Well, in fact, it may be, because kinetically, even though it doesn't have the half-life of these other formulations. There's certainly anecdotal data that it stops the attack. But again, we're being forced by insurance companies to limit the types of on-demand therapies that these patients have available. And so the conversations are much different than they were in the 1990s and even in the early 2000s. Patients who are the more severe patients are on long-term prophylaxis. Are starting to feel much more comfortable, and they're actually controlling the disease rather than disease controlling them, and their lives are becoming more normalized. In fact, I think as we do more quality of life questionnaires with our populations, we'll see changes that we would not have seen 10 years ago or even 5 years ago, given these therapies. No HAE patient is the same. We always implement shared decision making. We don't overexert our influence with a patient. We have to work with them, but we also do it within the means of what they have available, and what they're in terms of treatments and so forth.
Well, those are a lot of excellent takeaways from the conversation, Dr. Bernstein. And of course, we love the way you approach working with the HAE community and giving the patient a voice in terms of discussing and having an open discussion about what to do in the event of needing some dental care. And obviously, because of the great work that all of you have done over the years, we do have both prophylaxis therapies and on-demand therapies that are very effective. And I think that the input that you provided here today, I think helps to frame a discussion that one of our members of our HAE community can use to have a discussion with their doctor about dental care. I think, is it fair to say then, Dr. Bernstein, that your overall recommendation to people with HAE that you see is that they shouldn't delay or be hesitant to have dental care done because of the fact that there's a variety of different therapies available to both prevent and treat HAE attacks?
Yeah, that would be my recommendation. I think that discussion with their physician, very candid discussion. If they're only on on-demand therapy or not having frequent attacks, then certainly they can take the drug, an hour before or 2 hours before they go, and have an extra dose available afterwards if they feel comfortable with especially if they've had a history of having reactions. If they have never had, and they've had dental work or medical procedures and never have attacks, then they can just have an on-demand therapy available. If they're on prophylactic therapy and are not having any attacks, are not using any rescue medication, that's a discussion they have to have, depending on how invasive the therapy is and what the nature of their attacks are. If they still feel comfortable taking a dose before, that's a discussion with their physician they should have, versus just having it on demand available. These are not long procedures most of the time. The swelling can be obfuscated or confused with the local anesthetic, because they're injecting their mouth like this. So it can be difficult to differentiate, but the fact that they have these medicines that work very quickly and that work very effectively with the first dose in the majority of cases, and that they're on these long-term prophylactic agents that are very safe, I feel very comfortable making these recommendations and and knowing that our patients will not be in harm's way or be at risk for anything severely happening to them.
Well, thank you, Dr. Bernstein. This has been very enlightening. Thank you for the research that you did on this particular topic and the recommendations that you provided to our community about how to think about this, how to approach their doctors, how to frame the question. We greatly appreciate it. And thank you very much for your time.
My pleasure. Thank you for having me.